Hello, everyone. You're at the Silver Hill Hospital Grand Rounds, and we'll get started in just a moment as people are signing in. All right. Hello, everybody. Thank you for being with us here today. Welcome. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital. And today marks the return after what I hope is a good summer for everybody of our Grand Round series. We hope you were able to enjoy the summer, and thank you again for joining us today. We are privileged to welcome Dr. Hadeen Jaffe, who will be presenting on the topic Understanding Mental Health Issues Connected to Menopause and the Perimenopausal Period. And I will have the pleasure of introducing her in just a moment. Some logistics. We will end a little bit earlier than normal today, sometime between 12:30 and 12:45 Eastern Time. And I will moderate a Q&A discussion with Dr. Jaffe at the end of her lecture. This is a great opportunity to put forward questions and comments to Dr. Jaffe, which you can submit anytime during the lecture by using the Q&A link. So as slides come up and you have thoughts or questions, just go ahead and put those in. If you wish to receive CME or CEU credits, please complete the evaluation survey that will automatically show in your browser when we end the webinar. We will also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME to find commercial interest. And Dr. Jaffe will show a slide with her own disclosures. It is now my great pleasure and honor to introduce our guest speaker today, Dr. Hadeen Jaffe. And we had so many people interested in this topic. So I think it might be our record sign up. So let me tell you about Dr. Jaffe, who is the interim chair of the Department of Psychiatry at Brigham and Women's Hospital, where she is also the executive director of the Connor Center for Women Health and Gender Biology and founder and director of the Women's Hormones and Aging Research Program. She's the Paula A. Johnson Professor of Psychiatry in the field of women's health at Harvard Medical School. She's an experienced clinician and clinical reproductive neuroscientist whose research focuses on brain health in midlife women. Her research examines the mechanisms and treatment of neuropsychological symptoms in healthy midlife women and breast cancer survivors. We had so many people ask us for a presentation of this topic. And so I'm just honored that when I sent a note to you, Dr. Jaffe, that you said, yes, I'd be happy to join, even though you're at another conference right now. So thank you again for being here with us today. And I will go ahead and pass the baton to you.
Yeah, well, thank you, Dr. Katzman, and I'm so thrilled to be here and also so thrilled to know there's such an interest in this field. This field is near and dear to my heart. I've been working away at it since the mid-1990s, and there's been a lot of knowledge gained over this last period of time about how to approach this population, how to manage depression in midlife women, and what the relevance of menopause is. So I hope that everyone steps away from this with a greater appreciation and understanding, because this is not rare. You know, this is half the population, and we all take care of midlife individuals. Here is my disclosure statement. Most of my research is funded by the NIH, and so that's the research that I'm going to be presenting. I do have advisory roles, which where relevant right at the end I mention, and my spouse disclosures are not relevant to the work that I'm doing. So these are the objectives for today. First, to describe the prevalence and the course of both major depression or clinical disorder of depression, as well as what you'll hear a lot about, which is subthreshold depressive symptoms across the menopause transition. We'll then talk about common precipitating and co-occurring factors, and I'm going to focus on the hormonal factors and the menopause-related contributing factors in particular. The latter part will focus on treatment approaches for these conditions, both major depression and subthreshold. So, you know, this is where we are talking about. This is a stage of midlife and the reproductive and aging transition. in women in the late 40s and early 50s. And when I started in this field, we had very different ideas about what might contribute to our mood disturbance in this population. The the symptoms are really common. You know, when we think about menopause, we think about a range of symptoms, but I think of them as brain symptoms. You know, I'm a psychiatrist. I treat menopause and breast cancer patients. And although I'm not managing their gynecologic issues, the majority of symptoms that lead people to treatment are emanate from the brain, mood being a major one that I'll be talking about. So this was the notion, you know, now well over 100 years ago from an early father of our field, of Emil Kraepelin. And he had this notion of involution of melancholia, which was actually in one of the early DSMs. This is the idea that as people, particularly women, approach midlife in the 50s, that if there is a depression, somebody literally involutes and doesn't emerge out of it. So it had this kind of terminal stage of this terrible melancholic depression. And a lot of people were quite fearful about it. And I will tell you, fortunately, that we have been able to show that this is not the case. And it's a much more hopeful situation that was predicted. So the other sort of part in our history and our notion of what was relevant at the time came from this very famous psychiatrist book. And this was really foundational in our understanding about why women might get depressed in midlife and menopause. So I'm going to read this to you. And I know you're going to be laughing and, you know, shocked. But here it is. When a woman sees her womanly attribute disappearing before her very eyes, she is bound to get a little depressed and irritable. Having outlived their ovaries, they may have outlived their usefulness as human beings. The remaining years may be just marking time until they follow their glands into oblivion. So there was this whole psychological framework that midlife mood related to a sense of grieving and loss of reproductive potential. It's very psychologically based, and not that there aren't psychological aspects to midlife and aging, and I won't be focusing on that. But what we've learned in the last, 25, 30 years is a tremendous amount about the biology of what's happening and how to manage this condition. So just to make sure we're on the same page as to what menopause is and what the perimenopause, these terms get used very loosely sometimes. But, technically menopause is defined as 12 months without menses. So that's something that somebody doesn't know until the end, after they've gone 12 months. Then they look back and they know they've had 12 months of amenorrhea. Leading up to that is the perimenopause. And the perimenopause is on average 4 years, and it will be involved with infrequent menstrual cycles, movement towards irregular and unpredictable cycles. And that progresses over time. And then after this 12 months of this time of menopause is the postmenopause. And so on average, a woman in her mid-50s and later is postmenopausal. This is a visual that captures what's happening hormonally. We focus a lot, of course, on estradiol and progesterone. And so in the premenopause, you have this predictable cyclic entrainment across each menstrual cycle, of course, changing with pregnancy. In the perimenopause, in the early stage, there's actually wide excursions and high levels of estradiol. And then as somebody progresses to that official 12 months of amenorrhea, estradiol goes down. And then postmenopausally, the levels are low and unchanging. So the major take-home point here is that in the perimenopause, there's a lot of fluctuation and variability, and that's the body and the brain getting exposed to these ups and downs. Progesterone follows because it relates to ovulation, and there's only ovulation if there's a certain amount of estradiol, which is produced in the developing follicle. And hot flashes, which you'll hear a lot about because they're very linked with mild mood symptoms, really are most common during this period of time. So what about the most common symptoms of the menopause transition and menopause? The core symptom is changes in menstrual patterns, irregularities, and bleedings. And then, here are these next three, which are our symptoms. These are where we treat the brain. These are conditions that are a manifestation of the brain. And those are also among the most common. And then other vulvovaginal symptoms, which are more in the gynecology realm. I am going to talk very briefly about anxiety. So I wanted to put it on the radar here just to say that we know very little about anxiety and also irritability at this stage of life. But I will talk a little bit about this. So let's first step back and think about depression across the lifespan. So the risk of depression in women is twice that in men. 20% of women will have depression across their lifetime and 10% of men. And that's been shown in every study in every population. If you dig down a little bit and you think about what stage of life that depression risk is, you start to see, if you look on the horizontal axis here, that the age of puberty and the age of menopause are times when you see this divergence. You start to see differences in risk between women and men emerge during that time and continue during that time. And that has, and the fact that during the reproductive years in general, that you see this separation between female, all these studies being done at a time when we had very gendered notions of male and female and not a continuous notion, showed that across the reproductive ages, depression is much more common in women. I'd also like to remind everyone that depression risk is really a risk of recurrence. I think we have that in our framework, but our colleagues don't always. And the notion is that once somebody's had one episode of depression, they have a 50% chance of having a second episode. Once they have a second episode, the likelihood of a third is even higher, and so forth. The other thing to note is that women are more likely to have recurrence than men. And that's been shown in a number of studies over time. And so by the time somebody who is biologically female approaches midlife, they've had most likely to have already had an episode of depression if they're going to have one. And of course, we do see geriatric onset and age-related onset depression, but the vast majority of people have depression before midlife if they're going to develop it. So this is across the lifespan. What explains the successive risk? There are a number of factors that have the robust data in the range of these areas. The areas I'm going to focus on are really the later areas: sex hormones, neurosteroids, reproductive transition related factors, because I know that it's really important that people have an understanding and take care of our patients in a holistic way to feel confident about this information, know when to refer, know how to explain things. And so I'm going to focus mostly on, numbers 6, 7, and 8 here. Hormonally, just as a reminder, and I think I've said this before, but just, the perimenopause, this period of menopause transition, you see these ups and downs before the decline. So it is the brain, the body has to adjust. And I think it's beautiful that the brain and the body has this capability to adapt and adjust. And that is part of the biology of the female brain, is a normative adaptation to this. I'm going to skip through this and just highlight at the bottom here, the male brain, in contrast, really sees stability of androgens, testosterone across the lifespan. And so this is an adaptive way the female brain has been successful across both the menstrual cycle and menopause with these variabilities in cycle. And this is not a deep basic science talk, but I do want to just highlight how much there is in the brain that underlies the depression susceptibility in midlife. So estrogen targets, of course, are across the body, importantly in the uterus, the breast, etc., also the heart. But we haven't always thought of the brain as being an end organ target of what's going on with changes in female hormones like estrogen. Um, Over the last 20 years, as I said, there's been an explosion of science. And the take-home message here is that for every little dot and triangle, what we have here is evidence where either estrogen or progesterone receptors are active in the brain. And the point is, it's very broad. It's very broad across multiple brain regions and in connection with multiple pathways for neurotransmitter systems that we know regulate mood, like serotonin, dopamine, and others. And my last basic science mention here is something that I think is really pretty extraordinary, and that is that in rodent populations where you see an estrous cycle, kind of like the human menstrual cycle, there's fluctuation of estrogens or estradiol across the cycle, and it's a shorter cycle, but they have the same thing. And if you look in the bottom left here, one of the things that was just remarkable is that when estradiol is high, you see more interconnectivity between neurons. And when estradiol is low, you see reduction in this connectivity. So literally, there's an anatomic connectivity that varies across the estrous cycle in rodents. We don't have anything similar from humans, but that's extraordinary. It's anatomical. It's obviously physiologic. It's obviously, deep into the biology of the brain. The next thing I want to just make sure everybody is aware of when we think about hormones and the exposure of the brain to hormones, female reproductive hormones, we are mostly thinking about sources of hormones outside of the central nervous system, extra CNS sources. And so we're mostly talking about the ovaries in biological female. And that's hormones that are produced with ovulation and the menstrual cycle. And the concept is that these are crossing the blood-brain barrier, and that's how they're getting exposed to the brain. And that's why the brain might be sensitive to it in people who are susceptible. There is also intra-CNS production. So we know that the brain has the capacity to produce estradiol and other estrogens, progesterones, and also the main precursor to progesterone, which is allopregnanolone, which is now FDA approved as a treatment for postpartum depression. And so the area of exploration of understanding neurosteroids, hormones that are actually either coming to the brain across the blood-brain barrier and metabolized or generated out in the brain, has grown. Okay, so what do we know about depression and menopause? We do know that there is a risk of depression now that includes depressive symptoms and major depression or clinical depression. We do know that there is a risk during the perimenopause and also the very early postmenopause. Most of this for major depression is recurrence. And I've said this before, that it's very rare that somebody has their first episode of major depression as they're in the menopause transition. I do like to highlight some good news, which is that this is a period of vulnerability that's a window, meaning it's the opposite of involutional melancholia. It's a vulnerable period that people enter and then they age out of, or reproductively age out of. So when you look at dividing people into those who have no history of depression across earlier life versus those who do, studies have shown in both groups that there is a bit of a blip, especially in the perimenopause year leading up to the final menstrual period, and that as people get, especially 2 years after the final menstrual, remember menopause is technically 1 year from the final menstrual period. So as 2 years approaches, the risk of all this goes down substantially. The other way of looking at these data are in some recent data that we have in press, which is dividing people into those who in their early 40s, or had high baseline levels of depressive symptoms on a scale or low. And I know this is kind of hard to visualize, but the message here, when you look at this trajectory, what's happening to their depressive symptoms as they move through this, for those who have high baseline symptoms, they do continue to go down, but they go down a little slower, meaning there is a kind of a plateauing. So with age across the final menstrual period, ultimately is improvement, but that rate of improvement slows a little bit. And with those who have low baseline depressive, there's a small, very small increase across the final menstrual. You have to look hard to see that. So I want to highlight the importance of saying that this is not universal. And in general, there's a progression towards a better state and a better risk profile. And so we want to focus our efforts on helping people through this vulnerable period, knowing that not everybody is vulnerable. So breaking out mood disturbance, first you'll see major depression, then I'll go into depressive symptoms. Here there is this risk of recurrence for those who have a history of major depression, just like postpartum depression. Individuals who have a history of depression are at risk for postpartum depression. And some of the key risk factors include psychiatric history, anxiety, and medical illness. So somebody who enters midlife with a lot of medical problems is somebody who might be more susceptible to having major depression. When we look at specific menopause and hormonal factors, sleep disruption, which we'll be talking about later in more detail, is a key trigger for depression risk in menopause. When we look at depressive symptoms, the likelihood of depressive symptoms occurring is definitely higher than the likelihood of major depression. It is a period of risk, again, not in everyone, but in people with specific subgroup susceptibility factors. And here are some of the key factors. This includes, history of depression and current recent stressful life events and social support that's poor. BMI factors, racial minority smoking, lower activity. Menopause specific factors include these hormonal dynamics, the ups and downs of the estradiol, the progesterone going down, and also having a longer perimenopause and more hot flashes and sleep disturbance. So this really is a subgroup problem. I recognize everybody will have these hormonal dynamics. Not all of them will get depressed. So there's a subgroup of the hormonally among the hormonal susceptibility that contributes to this risk. If you break down risk factors into those two groups even further, you can see that the risk factors for the group that has high and low baseline depressive susceptibility is actually a little different. The hormonal factors are driving the high baseline. The anxiety and stressful life events are driving the low baseline. It's complicated. There's no one size fits all. There's no way to identify exactly, group people who are the perfect risk factor, but it's this constellation of symptoms that comes together. We pulled all this together into a recent review in the Lancet looking about mental health across the lifespan. And the outcome of this and the way it was reported in a number of high visibility press was to say that maybe there was an overestimation. Maybe in our effort to define and say that this is a period of risk, we made everybody think that it's universal, that everybody's at risk, or that it's going to be terrible. And when we looked and saw that they're really subgroups of people who are at risk, or periods of time that they're at risk, we wanted to be able to convey that a lot of people are not at risk, don't have the susceptibility, and can feel more reassured as they enter the stage. Because I see a lot of people who are quite frightened, and I like to be able to reassure them that we can monitor, but that I don't think they're going to have major concerns. The trade-offs with all this, if you try and tell people this is a risk factor, this is a period of vulnerability, is that we might frighten people, right? And so they live in anticipation that something will happen in their biology that will make them, deteriorate in their mood. And so we really tried to empower people with knowledge, be prepared, help educate clinicians where to be targeted in their efforts, and to think about treatment implications. So let's go dig a little bit deeper into that. Somebody is in midlife and in the peri or early post. How do you, and is depressed, or let's call this more the mild subthreshold. How do you know if it's related? How do you take a history? How do you establish the chronology? So here's some of the things that I do when I'm working with people with this. Firstly, I try and really establish, like, is this major depression or depressive symptom? What are we talking about? How much is it interfering? Of course, is there suicidality? How serious is it? Do they have a past history? Don't just think chronologically, think longitudinally. What's happening in their life? What are the major stressors in their lives right now? And there is no diagnostic test. There is no hormone test that you can say, all right, this is a depression and this is related to perimenopause or not by virtue of a hormone test. So when people come to you with tests, it can say something about whether they're perimenopausal or postmenopausal, but it doesn't say anything about whether that's the cause of a mood disturbance. Looking at all of the relationships, this is really important, between the onset of mood disturbance and the onset of menstrual cycle changes, hot flashes, night sweats, sleep disturbance. Trying to understand, firstly, do they have any of those symptoms and are they temporally related? And then drilling down on sleep is key. The sleep disturbance related to midlife and menopause is this interrupted brief awakenings. And that can happen with subthreshold symptoms. When somebody has a major depression, they have much more problems falling asleep. And of course, like, really important is somebody has early morning awakening where they wake up afraid to face the day. That's often an indication of a more severe depression. So just to share a little bit, what are we talking about with hot flashes? This is the thermoregulatory disturbance. This is the distribution here in red is where people perceive primarily the heat sensation. And this occurs in about 80% of individuals as they cross the menopause transition. There are changes in core body temperature, there are autonomic responses. This is, there's been a lot of work trying to understand the biology. It is in the brain. And that's the important thing I want to tell people. People feel like dismissed often, that they have hot flashes, they're not taken seriously, or they can't hack it or something. I'm sorry when that happens, because I think that people sometimes really do get that message. These are brain biology symptoms that are very disruptive and disturbing to people when they're more frequent or more severe. To have something like this once every 2 weeks is one thing, but to have many a day, to have them at night when people are waking up, think of it kind of like migraines sometimes also, how we conceptualize that. And there's been this extraordinary revelation of the underlying biology of hot flashes in this notion of what's called candy neurons, which secrete kisspeptin, neurokinin, dynorphins. And neurokinin has been identified, and these neurokinin receptors as being clearly indicators of hot flashes, to the extent that when you actually block the neurokinin receptors, the rat's tail doesn't get hot. You see it stay blue, whereas a hot flash in a rat is a red hot tail under these heat sensors. And this has led to development of some new medications for people with hot flashes. Let's also just talk a little bit about sleep and sleep disturbance. The sleep disturbance is incredibly common across midlife. The main symptom is this waking up repeatedly. You do get minor changes in falling asleep problems, but it's the waking up repeatedly, which is mostly attributed to hot flashes, but as you'll see, there are other factors. And there are many other factors, and oftentimes they can co-occur. People can have sleep apnea, which is a doubling of risk in this time of life. They may have mood as a contributor to their sleep problems, hot flashes, other things, bed partners, noisy homes, environments, major contributors outside of their own health. We've also shown that even when you take out the hot flashes and all these other factors, you can still see that even just the changes in the hormone, the lower levels of estradiol, also contributes to this sleep interruption, depression, as we talked about, and sleep apnea, as we talked about. So how are hot flashes and sleep disturbance and mood disturbance interrelated? So along the way, I've done a number of studies in very, very controlled environments where I've taken healthy volunteers and I've put them into a temporary medical menopause. This is using a medication that's widely available and FDA approved and used to treat endometriosis, fibroids, breast cancer, and prostate cancer. And we give people this, it's called Lupron or Leuprolide, and we give it to them so they briefly go into a very low estrogen state. And we know that some get hot flashes and some don't. So they've never had them before. So now we say, well, what happens? And the people who get hot flashes, does something happen in their mood or their sleep on a PSG or polysomnogram versus those who didn't get hot flashes? And we've broken the flashers into non-frequent and infrequent, as you can see here. And what you see here is that on the left is that, and this is the higher on this vertical axis, the worse the mood symptom. So the people who got more hot flashes nighttime hot flashes, had the greatest change in mood symptoms. The most mood symptoms emerged, and that was not seen in the daytime hot flashes. So we identified that it wasn't that people were bothered by daytime hot flashes and therefore had these mood symptoms. It was more the fact that they were having hot flashes at night, which of course has major impact on sleep. We were able to identify that sleep contributed, but independent of sleep, just having nighttime hot flashes contributed meaningfully. So here are the sleep data that we did, EEG sleep before and after. So people who had more wakefulness, spent more time in light sleep and worse sleep quality, all of them, of course, also had more mood symptoms. Shifting briefly to some of the work we've done looking at the hormone dynamics, we looked at a group of perimenopausal women with depressive symptoms, and across a 2-month period of time, we studied them weekly. We looked at their mood rating, we looked at their hormones, estradiol and progesterone, and their hot flashes. And the message here on the bottom left is that the more variable their estradiol was, so this is this group 30 to 40, that meant that across the 8 weeks, their estradiol was going up and down more than other people who just for that period of time happened to not have much variability. Those were the people who had worse mood. And then with progesterone, not having any progesterone, so not ovulating, actually made mood worse. So the take-home message here is that the more normative their hormones were, the more their profile was that looked like a 30-year-old who was having a normal menstrual cycle, the better their mood was. And conversely, the more abnormal, the more atypical and unpredictable, the worse their mood was. So how do I translate this into clinical patient care? I can say to somebody, she's going through a period of time of having unpredictable cycles. That doesn't 100% map onto what's happening hormonally. Like if people, might be skipping 2 months or something like that. You don't necessarily know what's going on with their hormones. But we know that some are making estrogen, some are not. And when they're making estrogen, but sometimes and other times not, and it's cycling, very unpredictably, and they're not making progesterone or ovulating, that's a period of time a window of time when they might have more depressive symptoms. But 3 months later, their hormone profile might look a little different, and they may be in a lower risk period of time. So very briefly, I'll just say, we're working hard on trying to understand neurosteroids and how they relate to perimenopausal mood disturbance. We don't know much about it. It is an area where I'm actively doing research. We know that, progesterone metabolites in allopregnanolone have multiple ways in which they may contribute to mood that could be protective. Remember, I said low progesterone, worse mood. So if you're giving allopregnanolone or giving progesterone, that can be protective, and that's something that we're looking into right now. Putting this together, we know in terms of the hormonal and menopause related effects that there are different pathways, and they're all kind of interrelated. It's very hard to fully disentangle them. And these pathways may contribute to the brain and the hormones, leading to mood disturbance, and of course, in part through having hot flashes and sleep disturbance. So, briefly to say with anxiety is linked, of course, with depression. Anxiety is linked with hot flashes as well. And sometimes it precedes and sometimes it follows. It's anxiety is, of course, linked with sleep disturbance and palpitations and others. And the one thing I want to say, because it's sometimes hard for people to disentangle like a panic attack or anxiety from a hot flash event, is that when somebody has a hot flash, they don't get short of breath. And of course, that's like really a core symptom of a panic attack. So if you're trying to distinguish, is that a panic attack or is it a hot flash, asking about short of breath is key. In hot flashes, some people just perceive the heat and the sweat, and some people have what I call an aura, a sense that something's about to happen. They can tell you, here comes a hot flash, and it might be a psychological kind of transient phenomenon. They feel very anxious, or they might have this more desperate doom kind of sensation, and that is very temporarily linked with a hot flash. And as it passes and they have resolution, that psychological experience resolved. I want to refer you to a paper that a group of us wrote, which I think is a nice paper from, I think, about 5 years ago or so, on guidelines for treatment for perimenopause by Dr. Pauline Mackey, and just encourage that it's a really nice summary of some of this work that I'm going to be describing, especially in terms of treatment. This is a good summary of pharmacological approaches to depression and you can, and related to menopause, and that's the column all the way to the right. But I did put in the column of hot flashes or VMS, and also sleep related to hot flashes or VMS, so that you can see how some of the treatments for one are also treatments for the other. And these treatments, break down into hormonal, non-hormonal, which are really psychotropic agents and treatments that work through the brain. Hormones work through the brain too. And then these novel compounds that I was talking about with neurokinin B blockers or antagonists. And this is the work that I described that I do consult for one of the companies working on this. And then there are behavioral therapies, which I think are really key. And there's just been a real explosion of interest in looking at behavioral strategies for all of these symptoms, so that they're not always a biological pharmacologic approach. So there are hormone approaches for hot flashes. There are hormone approaches for sleep, and this is hot flash related sleep, and which are the sleep benefits are pretty modest. And then there are hormone approaches for mood. And the main message I want to tell you here is, for major depression, severe depression, hormone therapy is not first line treatment. For milder depression, milder subthreshold depressive symptoms, when there's a lot of hot flashes, then it's a good option. And that's of all, if you remember one thing from this talk, please remember that, because if we give people hormones and give them an expectation for a major depression, a serious depression, that they are likely to benefit, we don't align with them around getting treatment expeditiously or as effectively, knowing what the data are out there. I know there are people who want to have a hormone trial, and if they do, then with you can see benefit, but it is usually within the first 2 months, so you're not going to give them a long period of time. In terms of non-hormonal therapies, antidepressants work for depression related to menopause. We did all these trials years ago showing that, and it seems kind of odd because, of course they would, but at the time we thought, well, if this is really a hormonally derived condition, we don't know if antidepressants would work. Really, the trials have been in serotonergic agents, so those are the treatments that we use. And of course, these serotonergic agents also work for vasomotor symptoms or hot flashes. Let's just go into the neurokinin antagonists and mood, just to say that we do not have data. And so, one of these drugs is on the market, and there's some sleep benefit with one of them, but we don't have mood data. So we're not in a position to say that this is a treatment for mood. And then the CBT treatments you see here, and we really haven't had CBT treatment tested for menopause-related depression, but I think it's really worthwhile for anybody across midlife in general. Digging down, as we've talked about, if you have somebody who has major depression, clinical depression, and hot flashes, how do you approach them? And then on the right, how to think about the pharmacotherapies for the milder condition. And I sort of said this, but just to highlight the main point here is that you see hormones on the right as an approach when there's prominent vasomotor symptoms, and then on the left, hormone therapy is not a first-line approach. Yes, there are data. There's a few small trials showing benefit, but it would not be a first-line approach. And then just to get wrapping up here, in terms of thinking about pharmacologic treatments for sleep disturbance, and this is somebody with hot flashes or vasomotor symptoms and having sleep disturbance. So the nature of their sleep disturbance is waking up repeatedly throughout the night. We did like a multi-center trial with all these different agents and about 1,000 women over multiple different trials. And the key take-home message here is that CBTI, which is the cognitive behavioral therapy for insomnia, is the most effective treatment for this sleep disturbance related to hot flashes. It did not take away their hot flashes, but it did help them sleep better. You can see in the blue, estradiol, estrogen was not as strong. And in the purple and the orange, you can see some benefit from serotonin agents, which is important because we think of serotonin agents, antidepressant, potentially worsening sleep. But in this group, these are non-depressed individuals with sleep disturbance related hot flashes, you get benefit. And of course, exercise and yoga were helpful. Pharmacologic approaches, we talked a little bit about. This is treating the sleep disturbance related to hot flashes. There are a number of agents that are available. Most of them are not on label. Orexin antagonists have been used and shown to be effective as well. So here's my summary slide of what I hope you've been able to capture from this talk, which is that there's two ways of thinking about mood disturbance related to midlife and the menopause transition: major depression and the subthreshold condition, with subthreshold being much more common, not universal, but much more common, and associated with specific hormonal, menopause-specific risk factors, as well as psychosocial support and anxiety. Major depression is much less common and is almost always a recurrence. And I really hope that that can be valuable for people as they manage their patients, as we know people are afraid of what might happen to them in midlife, that we can reassure people that the vast majority of people are not going to have major depression. We do need to learn a lot more about anxiety, but we can distinguish panic attacks from hot flashes. And in terms of hormonal therapy, it does work for the mild subthreshold symptoms when there's a lot of hot flashes, but it's not an approach for major depression, especially when there are no hot flashes. I'm happy to talk more about all of that. Antidepressants, serotonin agents are fantastic for this population. They're effective for treatment. They also will help the hot flashes, and they'll also help the sleep disturbance. So this is my slide really to say thank you. This is some of the people in my research group and my center from a recent gathering we had. And all the amazing collaborators that I've worked with and friends and colleagues, and also, wonderful support from the NIH over the years. So I'm going to take down my slides and turn this over to Dr. Katzman. But thank you again for, absorbing all of this. And I really hope it helps people in managing your patients.
Dr. Jaffe, that was amazing. Thank you so much. So many pearls of wisdom. I just can't really thank you enough. I have a question to start us off, and then everybody out there, we've got about, I don't know, 15 or 20 minutes or so to get questions answered. So if you want to put your questions in, go ahead. I was wondering, Dr. Jaffe, I think you're running a clinic, like a women's mental health clinic, I think. Can you say something about kind of referral to such a clinic versus treatment by general psychiatrists of menopausal, perimenopausal women, and when should somebody think about making a referral? How do you think about that?
Yeah. Thank you for asking that. So, yes, we have subspecialty clinics. This is subspecialty knowledge. You think about it like, child psychiatry or perinatal psychiatry, where there's a subspecialty knowledge, but the vast majority of people are being treated by frontline providers, and their primary psychiatrist, their primary pediatrician or OBGYN. And I think that's really important for menopause as well, because when you know somebody over time and you know their life, you know the context of this illness, your ability to care for them is obviously so valuable to them, to having a rich diagnosis and treatment plan, to following them. So I think if there were a case where there would be some kind of referral, I think the approach would be to have it be a consultation only. I think that's important. The other thing I recommend is that people get to know a gynecologist, a primary care doctor, a menopause specialist, sometimes an endocrinologist, somebody in their community who they get to know a little bit. Somebody who's interested in working with this population, has understanding and attention to the mood and psychological aspects of it. Get to know them, find out, you maybe already being referred patients from them, but find a way to work with them, because that's probably the best thing over time, because they can see them for a consult, because we can't know, as mental health provider, we can't know everything. And so, but we can know what questions to ask of somebody. Can you advise this person? Is this person going through menopause or not? Is this person a good candidate for hormone therapy or not? Is hormone therapy, something that should be withdrawn? All these kinds of questions, because, we are the experts in knowing the behavior and the psychology. And we can, if we work with somebody over time, we can be enriched by them and vice versa.
Great. Thank you so much for that. So Dr. Bernstein out there, right off the bat, sent in a few questions. I think she was likely excited to hear from you. And a shout out, hello, Dr. Bernstein. Let me ask you, I think you really covered this, but maybe we want to just highlight the answer. How do you differentiate the impact of poor sleep from menopausal symptoms for major depressive disorder?
Yeah. Okay. Thank you for that question. So firstly, when we say menopause symptoms, that can mean a lot of things. Most of the time, people are talking about hot flashes. But sometimes people are talking about generally like brain fog and sleep problems and hot flashes and fatigue and things like that. So the first thing is I take a cross-sectional diagnostic approach. Like, does this person meet criteria for a major depression episode now? Like, do I think this is an episode? And I take this question of, was there an episode before? So I think cross-sectionally and longitudinally. Because if they've had an episode before, then the likelihood is if they have an episode now, this is recurrence, right? And maybe just like postpartum depression, where there are triggers of stress and sleep, but this is recurrence of depression in a vulnerable life stage. The other thing I do is I really dig into the sleep. I'm a sleep doctor. Sleep medicine is so fun. You get to ask people questions about things that nobody asks them about. And it's really important because it's like every day, it's every day. How are they resting? How are they feeling restored? So asking about the nature of the sleep. is what's happens at night. Are they able to go to sleep when they want to? Um, as the evening approaches, are they afraid of sleep or nervous they're not going to be able to sleep? Are they preoccupied in any way? That's kind of that anxious predisposition related to sleep. And then do they wake up in the middle of the night? When they wake up, what is it? Cats jumping on heads, bed partner noise, the home community. People can't always get light and noise out of their home, trying to help like that. Obviously, children and parents and other family members coming in and out of the room. What's happening? Are hot flashes contributing? I mean, are they waking up gasping for air and apnea? Or are hot flashes happening? Are they waking up hot? Do they feel this sensation of heat across their upper body? Do they need to change their bed clothes? What's happening? And then are they waking up very early in the morning with a very anxious fear about the day? So I'm asking about sleep in part because if somebody's sleep disturbance is waking up hot, sweaty, uncomfortable, changing, but going back to sleep pretty quickly, that is typical for menopause and hot flashes. If they're waking up and then for whatever reason, they precipitate an awakening, but now what kicks in is the worry list or the to-do list, and everybody has these. And now they're anxious, preoccupied, they start ruminating, they can't go back to sleep. That often is very much related to mood disturbance. It might be mild rather than a major depression, but I really want to target that. You can help them get back to sleep. You can also help them prevent an awakening. So sometimes I work behaviorally around helping people get back to sleep. I'm a big believer in sleep hygiene and, not looking at the phone and not knowing what time it is, and also having a little book that is your to-do list or your worry list that is not something you look at in the middle of the night, but you tell yourself, I don't have to worry about that now because it's written down, it'll be there in the morning. So the nature of the sleep disturbance can sometimes indicate, whether this seems to be more a part of a clinical depression or a major mood disturbance as opposed to more of a hot flash related problem, which is much briefer awakenings. They're very bothersome. I don't mean to diminish that, but people do fall back asleep much more quickly.
Great. Oh my gosh, we have 31 questions that have now come in. So,
okay.
and we won't get to all of them, but that's an indication of the interest here. Marnie Ruling writes with a curiosity about women with vasovagal syncope or tendency toward fainting with hot flashes when they enter perimenopause. Will they have responses during a panic attack experience of hot flashes as anxiety or trigger a panic attack due to this? So are those increased, I guess?
Interesting. I've never been asked that. And I've, in all the years of treating people with menopause, I've not had vasovagal concerns come up. I do think though that the point, and it might just be a sorting, they go to somebody else for that rather than me. I do think the point about this panic attack and hot flash and the interrelatedness, something I mentioned towards the end, after this question. So, but that's important because they can feel interrelated for people who have panic attacks. And, they feel a hot flash coming on. They're trying to figure out like what's going on in their body. It can be hard for them to distinguish. So asking about shortness of breath is key to figure out which one it might be. But also, people may be comfortable not having treatment for every panic attack or every hot flash. But if they've got both and they sort of worry about, is one triggering the other, I always say, you know what? This is a vulnerable period. Let's help you with some treatment during this period of time. And then we'll reevaluate. How long before you reevaluate? That's a hard one because we have no way, unlike postpartum where the period of vulnerability starts, mostly in third trimester and early postpartum and then diminishes with time. We don't have that exact information, but we do know with menopause, but we do know that as somebody gets through that, like 2 years from the final menstrual period, a lot of the risk factors diminish.
There Sure. Thank you for that. Thank you. There's questions here about supplements for hot flashes. Shannon Dingle says that she recommends using evening primrose oil with a very good response. Dr. Bernstein
Yeah.
was asking about, Bettina Bernstein, about biosimilars and soy.
Yeah. So soy and primrose oil are weak estrogens, phytoestrogens, and so they are estrogens. So for some people, who that's enough to treat their hot flashes, it'll work for them. For people who have more severe, it may not work. Um, for anybody who should not be on estrogen, they should not be on those treatments. So we tell our estrogen positive breast cancer patients they should not be, taking any phytoestrogen source. So it's important.
Interesting. So question here, if someone has had a total hysterectomy, including the ovaries, would hormone treatment help them after many years without the hormones being produced naturally?
Yeah. I was talking about natural menopause, which is what happens just over the course of reproductive aging. So this person is asking a question about what's called a surgical menopause. So when somebody before the age of natural menopause has both ovaries removed, both is the important thing. There's a surgical menopause. That's then the main source of estrogen is withdrawn. So if they have one ovary retained, that this is not, you don't have a, it's really complex to think about it, but it really has to be both. So those people go into an immediate surgical menopause, and they often have pretty significant hot flashes. They can have sleep and mood problems. There's a lot of similarity. Um, they are depending if they're eligible to take estrogens, they're often treated with estrogens. Sometimes we treat them with non-estrogens to help them. What we do know is that their period of risk for having these symptoms, mostly hot flashes, but also mood and sleep, really goes away with time. So as they get further from that surgical menopause, their symptom risk is diminished, which kind of mirrors what we see across the natural menopause, right? It's almost like the body, the brain adapts over time in ways that is remarkable. Now, so the question here is somebody who didn't have hormones, maybe didn't need them or wasn't able to take them, could they take them later, many years later? And so I don't know that we have an answer. We do know that it is effective. Hormones are effective no matter what, typically, no matter what, stage people are in. But we are cautious with older women because of starting hormones after they've not had hormones for a long period of time, because of risk of heart disease and other conditions. So it's a very personal decision. This might be somebody who's very young, that's different, but we are careful, and it's not typical that they would be given hormones later on.
Great. Thank you. Thank you. Question from Helene Jacobs. Can you comment on menopause and melatonin production and the use of melatonin for sleep disturbance in this population?
Yeah, thank you for asking. Actually, I didn't comment on that or talk about that, and I should have. So the answer is we really don't know a lot about it. We know that melatonin and estrogens are sometimes considered interrelated in a reverse kind of inverse way. Melatonin, when it's used for sleep, is mostly known to be effective for jet lag related or circadian related sleep disturbance. But I know, of course, people use it outside of that. And some people have like circadian shifting, they're real night owls, and that can be very beneficial. But we really don't know about it. And of course, I think it's worth trying. In the same way that I tell people to wear sunglasses at night. I tell people, at night, in addition to don't look at your phone, wear sunglasses, get your brain, you start to reduce the light exposure to your brain, which allows your natural melatonin to be released. And you do that earlier, it helps you with a pre-bed kind of routine. So I got a lot of people wearing sunglasses at night these days.
Yeah. Wow. Thank you. Nellie Burdette says, excellent presentation, as that's kind of going through all the comments here. So I won't keep repeating that, but know it's there. And she's wondering, I think you mentioned this when you commented about depressant, but she's asking if you know of any work done looking into menopause across various racial and ethnic groups and the intersection of mood.
Yeah, so thank you for bringing that up. This is a major area of interest because we don't have a lot of data. What we do have data on are that um, Hispanic women and women who are African American have higher rates of hot flashes than Caucasian and certainly Asian individuals. So once somebody has hot flashes, at higher rates, more likely to have them, are going to have them more severely, have them for longer. We don't understand why that is. I'm so sorry, all these noises. Um, and so um, when somebody's hot flashes, then there are these other risk factors, sleep and mood factors. So there's some concern, and there's a little bit of evidence that the mood disturbance can be higher in minoritized, racially minoritized women. The other thing I'll say is that there's an area of interest in sleep and menopause where there are some differences in races that may be related more to the neighborhood and the community because of exposure to noise in the community. And that's another area which is not about race per se, but it's about density of the population and where people live and their ability to control their home environment or their sleep environment.
Great. I feel like I'm just firing questions at you here, but there are some questions here about the role of trauma, and does that worsen symptoms during perimenopause and many menopause? Is there any information about that or impact
Yeah,
hormonal
I
responses?
wish we knew more, but um, it's it's really an important question because if somebody has had some trauma and PTSD and they have a hyperarousal state and now they start dealing with hot flashes or poor sleep, if their trauma PTSD affected their sleep, you're adding on susceptibility and a kind of hyperarousal state that can I worry, and I think it's a population where I follow them more closely across transition, but we really don't know very much. So.
So here is a great question, Dr. Jaffe, from Allison Birch. They're all great questions, but Allison's asking, are there any other trainings around this topic that can be accessed and where? This area is not widely talked about at all. We are largely left to suffer through the symptoms.
Yeah. So I'm actually at the National Menopause Society, which is called the Menopause Society. I'm actually at the national meeting right now, and I was saying earlier that um, it it it's oversubscribed. Like it was, so many people wanted to be here. It's a hybrid meeting, remote and in person, and it's an annual meeting. And this society really takes very seriously all the behavioral, psychological, sleep disturbances. Of course, there's other aspects related to gynecology, and I think that's a good place. There are other national organizations that do work in this area. One's called NASPOG, North American Society of Obstetrics and Gynecology, and they have national meetings. And I think both of these organizations have CME talks and things like that, CME programs across the year. So I do think it's good to continue to be aware and to have, continue the discussion and the knowledge. I think there's some online groups. I mean, there's just been a tremendous interest in it recently, in part because um, the science has extended, and in part because people are saying, okay, how is it possible that we still know so little about something that's this common? And 20 years ago, we had the Women's Health Initiative, which is a major clinical trial of estrogen with or without progesterone compared to placebo for postmenopausal women. And the outcome of that meant that a treatment that was widely used in an ongoing way, hormone therapy, was really not offered to people. And also clinicians not always educated about how to use it, when to use it, and afraid of the risks. And so, within those 20 years, there's just been a lot of lack of information, and it's really coming into what people are experiencing. It's like, how do you learn about this when it's just not out there? So join us, like, please start a discussion group. I think there are a lot of people who want to know. Everybody knows somebody or will know somebody who's goes through this, because it's universal. So
Great. I'm going to ask you a last question here, and then because I know you are at this conference, and I just thank you so much for being here. Just even you're multitasking here. So questions. There are a few questions here asking about sexual desire and the impact of libido and its relation to menopause and perimenopause. And I wonder if you could comment on that.
yeah, another thing I did not address, but it is a really important area, and there are people who focus on this with their expertise. So one key point is that vaginal dryness and difficulty with lubrication increases across menopause and with time after menopause. So this is an important point, which is in contrast to the mood problems, which are window problems around for the, that are hormonally linked around the lack of estrogen in those tissues over time leads to worsening of this condition. Now, dryness and lubrication issues can lead to painful intercourse and, of course, lead to avoidance. And so it's not that dryness leads to pain or low libido in everybody. Some people have it, some people don't. Some people are not bothered by it at all. But so sexual function, when anybody has a sexual function issue, it's a matter of breaking it down into, is it, what is it? Is it dryness? Is it lubrication? Is it orgasmic dysfunction? Or is it desire? Or some combination? And so it may or may not be related, right? I mean, it could be related to many other things that have nothing to do with female hormones or menopause or biology. But asking the questions to try and understand if those are factors is really, really key, because estrogen treatment, local vaginal estrogen treatment, is really effective for that, and can really make a big difference to people's sexual health. So I think that's the main point to make, because there's a lot of other aspects, and this like a whole other area. But that's the key point: is it's not a window risk or condition, but it does accumulate, and it's treatable and manageable.
Great, thank you. Well, let me just say, Dr. Jaffe, I had spoken about loneliness at some point and had the most attendees, and you now have topped the record at 440 people calling in to hear you. So that's how much people value and want to learn about this topic, and value you speaking to us today. I just want to really express our gratitude for your taking the time away from the conference that you're at, actually, to speak to us today. And thank you, everybody out there who participated and continues to participate in our program. If you would like to receive CME or CEU, as I said, a link will appear, and just complete the evaluation survey that will automatically show up in your browser. And that concludes our presentation today. Again, thank you, Dr. Jaffe, and thank you, everybody, for joining us, and hope to see everybody in our next talk in a couple of weeks. Thanks, everyone.
Yeah, thank you so much. Thank you.